Thomson Thomson Breast Center and Icon Cancer Center, and supported by our event partner, Roche. My name is Dr. Choo Bok Ai, and I'm your host today. And we are joined today by 3 experienced breast cancer specialists, and myself included, who will be sharing with you the journey of breast cancer detection, on the diagnosis and treatment to help you achieve better health. And I'm excited today that there are a few hundred participants actually register. I just want to have some interaction with you. If you think that you're excited, can you just type for me so that I know that you are able to hear me loud and clear? Just type in excited in the chat box. Let's have a look whether it works, because in the same way, later there will be questions and answers as well, so that you actually can type in your questions and answer. So let me have a look. Okay. Now, I want to say that today's focus is on providing education only, and you should always see your doctor if you need personalized cancer care. So without much ado, I'll just introduce you the first speaker of the day. And we have with us Dr. Tanya Swan, which is also a breast surgeon and clinical director of Thomson Breast Center. And also my friend, Dr. Shang Yip, a medical oncologist at Icon Cancer Center. And myself, Dr. Choo Bok Ai. I work as a radiation oncologist at Icon Cancer Center, Singapore. We'll be addressing some of the concerns that you may have and covering the topics of management of early breast cancer. So the topic today are on, I found a breast lump and what should I do next? And that's addressed to Dr. Tanya Swan. And later, Dr. Shang Yip will talk about the latest treatment advancement in early breast cancer using systemic treatment from chemotherapy, hormonal, and targeted agent. And I'm going to talk about maximizing survival and minimizing the side effects in early breast cancer using advanced radiation. So we have worked together, 3 of us as a team for the past few years. And initially, all 3 of us are at Tan Tock Seng Hospital before we come out in private practice. So I believe that the best approach to management of cancer is always a team of doctors looking after one patient. So if you have any other questions that you want to raise, please do raise it at the Q&A time, and we'll try to answer as many questions as possible. And without much further ado, it's my pleasure to introduce my first speaker. And she's an accredited general surgeon with a special interest in breast surgery and more than 15 years of experience caring for patients, Dr. Tanya Swan. Prior to joining private practice, Dr. Tan has looked after patients in Singapore General Hospital, National University Hospital, and Tan Tock Seng Hospital during her training years. Dr. Tan is dedicated to providing prompt and accurate diagnosis for her patients in a warm and supportive environment, and has developed a strong network in multidisciplinary care to deliver the best model of breast care. So Dr. Tan is also the first female president of the SMA Council, which is the Singapore Medical Association, and she has been in the council since 2008. I shall now hand my time to Dr. Tan, who will be speaking on us on early detection and diagnosis of breast cancer. Dr. Tan, please.
Hello, good afternoon, everyone. Thank you for spending this afternoon with us. So a lot of times, I am the first point of contact for many of the ladies who self-detected something, whether it's a breast lump, an abnormal nipple discharge, or any kind of discomfort they experience. So when they first meet me, I find that some of them are really panicky and frightened, and I hope to be able to share with you some facts about breast cancer, and more commonly, all the other lumps are non-breast cancer, to allay some of your fears. So let's get started. The first thing you do when you feel a breast lump is actually to stay calm, don't panic, and just make an appointment to see a doctor. A breast lump can be any one of the following conditions. It can be just normal hormonal lumpiness. It could be a breast cyst, fibroadenoma, Phyllodes Tumour, a fat necrosis, a lipoma, and finally, cancer. So what exactly is inside the breast? The first layer on the outside is skin, and of course, there's some fat, which varies according to our own body shape. The breast tissue itself has a certain lumpy quality to it. And if for some of the ladies here, you might notice that as your menses approach, it feels a bit more sensitive, a bit harder and lumpier. And after the bleeding has stopped, it tends to soften. That is a normal response of breast tissue to hormonal changes. Then below that, we have the muscle and the rib cage. So a lot of ladies come to me sounding very frightened and say they have very lumpy breasts. I would like to reassure everyone here that lumpy breast in itself is really normal, and that is the texture of breast tissue itself. As mentioned earlier, during the menstrual cycle, from normal breast, some areas, some of the milk ducts will swell a little bit to form tiny little water cysts. And for some ladies whose changes are very persistent, they might even have a biopsy to confirm it's nothing serious. And all of this spectrum of changes are within normal. For some ladies, the breast cyst doesn't disappear after the menses, but keeps on accumulating the fluid. So it becomes a larger lump and you are able to feel it. So this happens for any lady who's still actively having our periods, and they become less common after a lady has entered menopause. So when you do feel a lump like this, one of the ways that we do is to put on an ultrasound, and something that's very smooth and round and black color implies water, and this is definitely benign. Whether or not we need to do anything depends on the size, the location, and whether it's causing you any discomfort. Fibroadenomas are another common non-cancerous lump that's common in the younger age group. These are very sensitive to normal hormones. So during puberty and during pregnancy, these lumps tend to grow in size. So all that's needed is a closer monitoring. The fibroadenoma in itself doesn't transform to a cancer because it comes from a different cell compared to a cancer cell. But sometimes, if the lump is next to a milk duct and that duct has a cancer, we find that the lump seems to be larger. A biopsy will confirm which portion is the cancer, and then they proceed for treatment. So if you do have a fibroadenoma, do you need to remove it? Usually no, unless it keeps growing and growing, or you keep feeling it and you get really distressed by it. In a small group of patients, this kind of fibrous lumps are a separate category called Phyllodes Tumour. So this kind, they tend to grow really, really fast and double in size rapidly, such that we have patients who present with a huge lump like this out of fear or out of misunderstanding. So even when it's so big, such lumps are usually not life-threatening. They are locally aggressive, that's the medical term. All it means is that it grows very fast within the breast area. Less than 10% would be the kind that spreads to other parts. So we don't actually call this breast cancer. This is a very specific kind of tumor called a Phyllodes tumor. Fat necrosis literally just means dead fat. So we do have some patients who can share a very definite story where the child, the grandson, kicked them in the breast area or ran into them, or they tripped and fell and knocked the chest against the hard edge. What happens after that is the blood supply to the fat gets disrupted and the fat sort of died. And then it comes as a painless breast lump. Mammogram and ultrasound should be able to tell us that it's just dead fat and we leave it alone. Fat is a different problem here. So lipomas are fatty lumps that can happen anywhere in the body. When it's within the breast, ladies think of cancer, but again, the mammogram and ultrasound will tell us that it is a non-cancerous lump. For some patients where there's some nerve fibers within it or more blood flow, it's a lot more sensitive, so they request for surgery. And of course, this is what most patients are worried about, breast cancer. So when you do feel a breast lump, what happens next? When you see me in the clinic, the first thing is actually just a thorough conversation to assess your risk of having cancer. Age is actually the most significant risk factor. The older we are, the higher the chance of cancer anywhere in the body, not just for the breast. Other factors that affect our risk of having breast cancer are hormone related. When do you first have your menses? How many children do you have, if any? How long do you breastfeed for? Do you take any extra hormones such as contraceptive pills? All these help us to make up a risk profile that's individualized for yourself. Next, there'll be an examination for me to check on the lump, to confirm the site, the location, the size, how soft or how hard it is. At the same time, I'll examine to look for any other symptoms such as a nipple discharge or any lumps in the armpit area. based on your age and what I find, I would recommend the necessary scans, usually a mammogram if you're age 40 and above, with an ultrasound as well. Then finally, at the next review, we look at all these things and we proceed for biopsy only if necessary. So a mammogram is an X-ray of the breast. Here I'm showing two pictures. On the left side is a lady, usually older age group. The breast tissue has shrank, and that makes the body fat more apparent. This is good because small cancer is more easily detected. In the majority of ladies here, though, we find that maybe our body fat content isn't as much, and the breast tissue is still very thick. So what that means is that some of the small cancers get overlapped with normal breast tissue and it's harder to see. Even then, the mammogram is of definite use in screening for other kinds of changes. So in ladies with a dense mammogram, a lot of times we'll add on an ultrasound. And ultrasound uses ultrasound wave technology, same as that for scanning babies, to study the lump. So it is radiation-free and it is safe. So this picture shows we're able to see the size and shape of the breast lump, as well as check the armpit area for any abnormal lymph nodes. Then for ladies who need a biopsy, this is what happens. If you're not familiar with the procedure, let me explain. It is done in the clinic, usually under local anesthetic. We give injection to numb the skin, followed by a really tiny cut. No stitches are required, just a plaster to close the wound. I use the ultrasound to find the lump and then insert the needle to locate it. What is actually extracted are small little pieces like these, and then these go to the lab for the lab specialist to do their additional tests to confirm what the lump is. During the biopsy, so this is the device I use in the clinic, the ultrasound on the Android phone. This is a gun. This is a biopsy gun with a special spring device to push the needle out really fast. Then over here, I am able to see the needle positioned at the lump and the needle passing through the lump to be sure that we have sampled the lump accurately. Now, if a cancer has been diagnosed, what happens next? The lady will need to go for staging scans. This is to check whether the cancer has spread to any other parts of the body. There are a few different kinds of scans available. The one commonly done in our practice is the PET-CT scan. In addition, based on the specimen that we have, we instruct the lab to do additional chemical testing to check for these three main components, ER, PR, and HER2 status. This will tell us whether that cancer cell is sensitive to certain female hormones or whether there's a need for additional treatment to suppress the growth. After that, my role as a breast surgeon is to initiate the discussion on the treatment options available. Some patients are suitable for surgery first, followed by chemotherapy. Some patients will need chemotherapy first, followed by surgery. For some patients, they will need additional radiation therapy. Finally, for a group of ladies who have cancer spread to other areas, they go on a treatment path called palliative treatment. There's seldom any need to make an immediate decision on treatment. I strongly recommend my patients to see the relevant specialist to discuss the pros and cons before deciding. So that would be someone like myself, a surgeon, a medical oncologist, as well as a radiation oncologist. There usually isn't any rush, as I said, but of course, don't delay. Taking a few days to a few weeks to get all the logistics planned out and to discuss with the family on the best option is all right. But of course, don't wait for months later to embark on treatment. So a staging scan, we sometimes tell patients like going to a space machine. So you lie down flat, the X-ray department will give a little injection, and then you enter a little tunnel. What it does is to give you a 3D X-ray of the body. Some examples I show here. Over here, we see an image of the heart with a small lung, with a small lump in the lung. If a patient has a confirmed breast cancer, this is worrying for a spread to the lung. And this example here shows a very large right breast cancer, and the whole purpose is for us to do the surgery planning. In this patient, the cancer is so big, it has gone into part of the bone. This patient will need chemotherapy before proceeding with surgery. In this patient, we see multiple lumps in the liver So this, again, in a patient with a confirmed breast cancer, this represents spread from the breast into the liver. Then when we talk about additional chemicals, all this work is actually done by the lab specialist, and that's a whole different subspecialty in itself. They use different chemical staining to determine the ER, PR, and HER2 status. Then what I discuss with the patient then is the kind of surgery. In treatment of the main breast cancer, some patients will need a whole breast removal, also known as a mastectomy. This can be done together with reconstruction for the younger ladies, or rather the healthy ladies. Age in itself is not a strong factor. In some patients, they are suitable for partial breast removal, also known as a wide excision or a lumpectomy. During the same surgery, most breast surgeons will also check the lymph node for any spread. So if the ultrasound is normal and there's no confirmed lymph node spread, we do a procedure called the sentinel lymph node biopsy. Sentinel means a guard. So the theory is that the guarding lymph node should be able to capture any abnormal cancer cells. And if this is normal, we assume the rest of the lymph nodes are normal. In some patients, if the first guarding lymph node is affected and there's cancer spread, it is still wise to remove all the visible lymph nodes, and this is known as axillary clearance. So the factors that make us decide which which surgery to choose, there's a few things to consider. The main thing is actually the size of the cancer, which part of the breast is it in, and even how many cancers does the lady have. We do have some patients where more than one cancer within the same breast, and for them, they might need to have a whole breast removal instead of a partial breast. Next, genetics analysis is getting more popular now, and having a genetics test done before the surgery may help. If someone does have a genetic mutation, they are suitable for doing a preventive surgery to remove the normal breast as well, so as to prevent future second cancer. Additional things that we consider are the personal health, lifestyle. For example, ladies who are smokers, who are diabetic, or who have other serious medical conditions might need to do a shorter and simpler surgery. Then for some ladies who are in some kind of service industry with tight-fitting uniforms, or ladies who are not, who don't have a life partner yet, they might choose to have the reconstruction or partial breast removal so as to preserve their own natural breast and shape. So this picture shows some examples of the surgery. Top left shows a mastectomy, where we just have skin and some fat over the chest wall, and it leaves a long line. The bottom picture shows a lumpectomy with an axillary scar. So we make a scar over where the tumor is, and another one to check the lymph node. Then the last picture shows a lady who had reconstruction. This type of reconstruction was actually a tram flap, muscle and fat taken from the tummy area. So with that, I conclude my talk. Thank you very much.
Thank you, Dr. Tan, for the valuable sharing. We have some questions for you actually, because they've been asking in the Q&A. So I'm just going to present the questions to you, and hopefully you can answer some of them. So one of the questions was asking if my mom has breast cancer, should I start screening early?
Thank you for the question. So among specialists, the family history is relevant, and perhaps to share a bit more with the audience here, the family history that's more significant will be first degree relative and also the age at which the relative had the cancer. So if your mother had cancer at maybe say above 50 years old, there's a good chance it might not be genetic, but it could be just related to old age. So your risk of cancer may not be that much higher. Okay. Another common rule of thumb that most specialists use is we take the age of the first patient in the family with cancer and we minus 10 to recommend the screening age. So if your mother had cancer at age 50, we minus 10, you should start screening at 40, which is the standard recommended age for screening. However, if a patient tells me that her mother had cancer and passed away in her 30s, when the patient now is just an infant, that is suspicious for a genetic basis. And for this patient, even though she might be in her 20s or 30s now, I would recommend screening But in such special conditions, the screening will not be a mammogram or ultrasound. It will be something else, for example, MRI. So for any of the audience here who has a family history and not quite sure what to make of it, good to schedule an appointment with any of the doctors to discuss further your risk.
Okay, thank you. There are two questions related to actually breastfeeding, because we know that cancer sometimes can be seen in younger women. So what's your experience of breast cancer happening in actually patients is actually still breastfeeding? And would you recommend mammogram or ultrasound when one is still breastfeeding?
Wow. Okay, breastfeeding, of course, at Thomson, being a maternity hospital, we see a lot of ladies with breastfeeding issues. Majority will be all right, but we have picked up a few with cancers. So in general, during breastfeeding, we expect more lumpiness in the breast, and this may fluctuate. Doing an ultrasound is of some use to look for suspicious solid lumps. A mammogram is not advised because, number one, the age of these mothers tend to be younger, so a mammogram is too dense to be of use. Number two, a mammogram has a small amount of radiation, and we just don't know how much stays in the body, so it's not safe for the baby. Warning signs of cancer is always a persistently hard area that doesn't go away. Number two, traces of blood in the milk. If it disappears after 1 or 2 feeds, that is normal. If you find that it's always there for a few days, do speak to a doctor and get a more thorough check.
Okay, thank you. Now, sometimes the report of ultrasound or MRI, the mammogram has come back. Let's say, for example, one of the participants is asking, the ultrasound report showed that there are 2 small hypoechoic nodules, which are benign features. So what do you do with ultrasound that most likely benign? How often do you actually follow up on them? And do you really need to biopsy everyone, or what should be your follow-up appointments?
Yeah, very good question. So to put things into context, let's think back to why you had the ultrasound. For some people, it's part of a health screening by insurance. And if these are found by chance and the report is benign, you could just have an ultrasound follow-up in about a year or even 2 years to make sure they stay stable. If you had the scan done because you felt a lump, then we need to check, is this truly the lump that you felt? So the simple answer is no, not all lumps need to be biopsied. Second take-home message is, if you do have a lump on ultrasound, it's good to have another follow-up in 6 months to a year, depending on the rate of growth. If there's no growth, then it's great, leave it alone. If there's an increase in the growth, let your doctor speak with you whether or not you need to do something about it.
Okay, that's good. Thank you very much. Just one other question. There are a lot of questions that we cannot probably answer everything, but I just want to ask it, how about nipple discharge? In your opinion, will nipple discharge a common presentation of breast cancer?
Actually, yes. Nipple discharge is a subtle sign and not commonly talked about by a lot of awareness groups. So the pathology, the cancer grows within milk ducts, right? And depending on which part of the breast it grows from. If it's growing from somewhere very far behind, deep inside the breast, it might not come out through the nipple, all right? And it will take time and grow into a lump that you can feel. But if the cancerous change is happening nearer to the nipple, and just by chance it appears as fluid or blood on the bra, on the clothing, or let's say when you touch and you see it, do come in for a check. Our whole idea of early detection is to try to catch cancer in the very early stage, as a stage 0 DCIS cancer. Then that gives us the best chance of curing the cancer.
Okay, thank you very much. So Yiswan, there are a lot more questions actually in the Q&A. Maybe you can answer it offline and type in the chat group.
I will. No worries.
We'll welcome the next speaker for that so they can continue with the talk. So next up, we have Dr. Shang Yip. Dr. Yip has over 10 years experience in clinical practice in medical oncology. He passionately believes that caring for patients with cancer involves caring for their physical, emotional, and spiritual health. And with kindness and compassion, and providing each of his patients with the best evidence medical treatment. Dr. Yip was a consultant in medical oncology at Johns Hopkins, Singapore. At that time, he was based at Tan Tock Seng Hospital from 2011 to 2015. And so he specialized in breast, urogenital, gastrointestinal, lung cancer, and melanoma. So he was in charge of the Tan Tock Seng Oncology Clinic previously. and was the principal investigator of multiple clinical trials during that time. So Dr. Yip is currently a fellow of the Royal Australian College of Physicians and also the Academy of Medicine Singapore. I will pass the time to Shang to share about his latest treatment advancement in early breast cancer. So I pass the time to him now. Dr. Yip, please.
Thanks, Dr. Choo. All right, let me get my screen on. Okay. All right, good to have everybody here. And I have to say, every time I do a talk on the weekend, I'm always amazed as to how many people turn up. And I'm especially amazed that, at the start of phase 2, when everybody should be going out and celebrating, we have like over 200 people at home listening to, happy to give up their time to listen to us talk. So I'll try to make this useful. Obviously, I noticed on the last session, there's a lot of questions. So intentionally, I think all of us have kept our topics really short so that there's lots of time for questions. However, I think even in the few questions I noticed earlier, you'll find some of the answers in the slides that I'll be sharing. So I'll only take about 15 minutes to share, and then we'll leave plenty of time to answer your questions. So I'll be talking about the latest treatments for early breast cancer. Okay. Okay. The most important thing to know about early breast cancer is that it is curable, right? We know that breast cancer incidence, that they're getting more and more breast cancers around Singapore and the whole world. And every person, you will know a friend, you'll have a family member who has had cancer, and breast cancer will often be something that is very common because it's the most common female cancer. But as much as breast cancer is increasing in its incidence, the survival rates for breast cancer have also improved. And we now know that almost up to more than 90% of early stage breast cancer patients are cured. So that's something to be very positive about, and that's probably why a lot of people like Dr. Tan, Dr. Choo, myself, I have to say we particularly have a passion and enjoy looking after breast cancer patients, because it is one of those cancers that has made so many advancements and is generally curable, especially when it's caught early. Now, in order to do that, as Dr. Choo mentioned, it's a multidisciplinary thing. So it requires people like, I think so one of the questions I saw was, who do you need chemotherapy, radiation, surgery? And often it's a combination of all three in order to cure the cancer. You rarely, for breast cancer, will you need only just surgery or only chemotherapy. And often it's a combination of all different disciplines, which is why today you have a medical oncologist like myself, a radiation oncologist like Dr. Choo, and a surgeon like Dr. Tan, who you've just had. So, and these are like I said, these are the treatments that you often need for most patients with breast cancer. You'll need surgery, radiation therapy, chemotherapy, and often hormonal therapy. But today I'm going to be just focusing on my section on what a medical oncologist and why you might have to see a medical oncologist. So what a medical oncologist may offer a breast cancer patient is hormone therapy. So majority of breast cancers are driven by hormones. So we still use hormone therapy. We've used it for about 40 over years to help manage breast cancer, and we continue to use that a lot. We also have a newer type of treatments, things called targeted therapy, which is not chemotherapy, but treatment that is very much very accurate, doesn't kill the good cells, and targets only the cancer cells, hence the name targeted therapy. And then, of course, everybody, without me having to talk too much about chemotherapy, everyone knows a bit about chemotherapy. It's still an important part of the treatment of breast cancer. So we still continue to use it. But I'll talk a little bit more about most of them I'm going to talk a little bit about today. So the first one we should talk about is chemotherapy, right? Look, chemotherapy, everybody knows a lot about it. Like I said, you'll probably have a friend, a family member, or yourself having gone through chemotherapy before. But I think today I'm just going to be giving you updates on changes in the way we treat breast cancer. So it's very important to think about chemotherapy or rethink chemotherapy, because there are some things that have changed the way we give chemotherapy for breast cancer patients. And the most important thing is really this. I think over the last 5 years to 8 years, there's really been a push to say that I think we're using a bit too much chemotherapy. Why? Because, you know, about maybe 20, 30 years ago, everybody was terrified of cancer. So if you see a patient with cancer, you want to throw everything at the cancer. You want to do whatever you can to beat the cancer. So we gave really strong doses, really almost everybody got chemotherapy, whether you're stage 1, stage 2, you know, we just give the chemotherapy because number one, we didn't have a lot more other than chemotherapy to give. And number two, we were just afraid that, you know, we don't want this cancer to come back. So we probably used a lot of chemotherapy in the past. But in the last few years, what we've done is to see, is there ways that we can cut back? Maybe patients will still be cured with a bit less chemotherapy. So a lot of research has been going into this. And thankfully, the results have been good. And really the thing that has allowed us to use a lot less chemotherapy is this particular genetic test that we do for a lot of breast cancer patients now called Oncotype. And I think there was somebody who asked a question about this earlier. So with the Oncotype, and Oncotype is just a genetic profile test. What do you mean by a genetic profile test? We all know that all breast cancers are different. So when somebody has, even if you have the same breast cancer, you may have a stage 1 breast cancer like your friend and your colleague, and you'll find that all three of you will have completely different types of treatments. And that's because genetically every cancer is a little bit different. And now we have the ability to find a specific genetic profile of your breast cancer if you have one. And how we do that is through the Oncotype assay. So genes in the breast cancer, and once we do that, the outcome of this is we basically have an understanding of how aggressive your cancer is. So if it's a not aggressive cancer, what we call a low risk cancer, often these patients will not need to do chemotherapy. But if you come back, the genetic mutation suggests that it's a high risk cancer, then most of these patients will need chemotherapy. So probably the largest breakthrough in the last 2 years is that we found out that even patients with a moderate risk or intermediate risk patients, even those patients nowadays can do without chemotherapy. So that's one way in which we've cut back the use of chemotherapy for many patients now. So traditionally, a lot of patients, like maybe 10 years ago without Oncotype, a lot more patients would have gotten chemotherapy, and now we have a lot less of them who need it. Likewise, you know, for other types of breast cancer, we have these, some of you may have heard about what a certain type of breast cancer called the HER2 positive breast cancer. Now, HER2 positive breast cancers are a very aggressive type of breast cancers. So, you know, like when we first knew how aggressive it is, it was one of those cancers that we used to give a lot of chemotherapy. Almost all patients got like 6 whole months of chemotherapy, whether it was stage 1 or stage 2, we gave them a lot of chemotherapy. But thankfully, once again, with new trials coming out, we found that stage 1 HER2 positive breast cancers, previously they may need, you know, 5 to 6 months of chemotherapy, but now we found that just by giving them 3 months of fairly gentle chemotherapy, most of them, more than 90% of them, will be cured of it. Okay, so that's really a big update, a big change in the way we think about chemotherapy. We're using it less and less for early stage breast cancers. However, I must say that it is still a very important component, and a large majority of patients with breast cancer still will require chemotherapy. Next, we talk about some updates in targeted therapy. Now, for targeted therapy is, like I mentioned, the HER2 positive breast cancers are a special type of breast cancer that makes up about 20% of all breast cancers. We now have new kind of drugs for HER2 positive breast cancer. Many people would have, if you've had breast cancer or had relatives with breast cancer, you would have heard of this drug called Herceptin. That's been around for almost 20 years already. But now we have even better drugs, you know, for early stage breast cancer. So Kadcyla, it's like a special drug that incorporates a little bit of chemotherapy within the Herceptin drug. So we now know that Kadcyla, for certain breast cancer patients with HER2 positive disease, do even better than Herceptin. So we got new drugs, as always, with oncology, as always, advances. We also have other types of drugs, another drug also for HER2 positive breast cancers called neratinib. And some patients, we find that even after all the chemotherapy, after 1 year of their Herceptin, still have a fairly high risk of relapsing. And obviously, you know, with early stage breast cancer, our goal is to cure the cancer, to make sure it never comes back. So now we know that some patients may need some extra treatment, some tablets, naratinib tablets, and now we have these tablets that we can give to patients after they finish their 1 year of Herceptin. And all this all helps in curing the cancer. Okay, so like I said, I'm going to keep it short, but there is one important part of breast cancer treatment or cancer treatment that we must talk about, because most people will have already heard about it. And that is the immunotherapy. Now, immunotherapy is the newest way in which we treat cancers. And what it is that it's only come around only for about last 7 years or so. And finally, around sometime last year, the two professors who invented immunotherapy were awarded the Nobel Prize for immunotherapy in cancer because of the incredible breakthrough that's provided for many, many patients. Basically, immunotherapy has allowed us to cure some stage 4 cancers, which we previously couldn't cure. The best example of a stage 4 cancer that used to be incredibly very difficult to treat and terminal almost was melanoma, a type of very aggressive type of skin cancer, which is very common, especially in places like California and Australia. And you know, stage 4 melanoma used to be, if you get it, you would be dead within 6 months to 12 months. And now, because of immunotherapy, many of these patients who have stage 4 melanoma are actually cured of it. So previously, like 10 years ago, they would have died within 6 months. And now many of them, once they get immunotherapy, actually are completely cured of this cancer. So how immunotherapy works is that and that's what excites most patients, because it kills cancer cells by activating our immune system. So unlike chemotherapy, targeted therapy, which go into your body and directly kill the cancer cells, immunotherapy doesn't do that. It actually it's still a drug and an infusion that goes into your body. But what it does is that infusion then finds your immune system and stimulates your immune system. So it activates your immune system and then uses and harnesses your own body's immune response to search for the cancer cells and kill the cancer cells. So we found now, because we've used it now for about 7 to 8 years, that it's effective for many types of cancers. Of course, because it doesn't kill the good cells, it has much less side effects compared to chemotherapy. And like I mentioned earlier, most important of all is that previously incurable cancers, we're now seeing long-term remissions or even curable, making it curable. So that's what makes it, and that's why those guys won the Nobel Prize. Now, why, however, I put it as like why I've very rarely ever shared about immunotherapy in any lecture for breast cancer is because, unlike other cancers, breast cancer has really trailed behind. You know, so it's like immunotherapy in the usage for many cancers like skin cancer, lung cancer, kidney cancer. We've been blazing ahead for many years, and we who have been looking after breast cancer patients have felt very left behind, because we've tried it for our breast cancer patients and found that it didn't work. They did trials for it and found that, unfortunately, it was all very disappointing. For some reason, breast cancer just doesn't seem to respond very well to immunotherapy, unlike many other cancers. So, you know, many of my patients ask me about immunotherapy, and often I will tell them that there's no point using it years ago. So breast cancer, immunotherapy in breast cancer has really been lagging behind compared to its use in a lot of other cancers. But until now, you know, and so finally, you know, we have something. And I think that's what's exciting. So sometime around the end of last year, we finally, and this was very exciting, you know, when all these results were published, when we found out that there is now a immunotherapy drug that works well for early stage breast cancers. And it's a drug called pembrolizumab. It's one of the earliest immunotherapy drugs. It's probably still the one that's most commonly used. And now we found that if we give pembrolizumab or Keytruda for early stage triple negative breast cancer. Now, triple negative breast cancer is one of the most aggressive types of breast cancer, you know, and it's still probably of all the early stage breast cancers, it's probably still the one that's hardest to cure, hardest to treat. But now I think that this is changing. The game is changing a lot for early stage breast cancers for triple negative, because we now have shown that immunotherapy works only for this group of breast cancer. So we used to always be disappointed or a little bit worried if we see patients with triple negative breast cancers, but I think that's going to change because as of last year, this trial showed that it's a complicated slide, and I don't expect you to understand it, but if you hear what I'm saying, it basically if you add immunotherapy to chemotherapy for triple negative breast cancer, it greatly improves the response rate of the chemotherapy. So what that means is that if we just gave the immunotherapy alone without the chemotherapy for breast cancer, it probably won't work. And that's why we were always disappointed when we did immunotherapy for breast cancer, because it doesn't seem to work very well on its own. But when we found that if you combine immunotherapy with chemotherapy for this particular group of breast cancer patients, the response rate greatly increases. So we're going to probably be using a lot more immunotherapy for early stage breast cancers, not for all breast cancers, only a small group of breast cancers called the triple negative breast cancers. Now, having said small, because there's so much breast cancer, triple negative breast cancers make up about 15% to 20% of all breast cancers. So there'll be a lot of patients who will benefit from this. At the moment, this trial, because it was only just published recently, immunotherapy is still not FDA approved for use yet, but I think it's only a matter of time. Once the trial results mature, this drug will be a new way in which we can treat breast cancers, and it's particularly a particular group of breast cancers that were notoriously more difficult to treat compared to a lot of the other cancers. Okay, so like I said, I have intentionally kept my talk a bit shorter, so we have plenty of time for questions.
Thanks very much, Sheng, for your very adequate talks. Quite difficult to do the whole systemic treatment in one short talk, because there's so many things that can have to be considered. So I just looking through the questions, I just want to bring with you some of the attention that actually a lot of people are asking about hormonal treatment with tamoxifen. So for example, what are the really, in your opinion, when you already see patients, what are the most common side effects of hormonal treatment, and how long do you need to take it? And do you see people actually stop the hormonal treatment earlier because of side effects?
Yep. So yeah, it's good that there's a lot of questions about hormonal therapy. I didn't talk much about it, mainly because there's not many new updates in the use of hormonal therapy for breast cancer. Now, hormonal therapy for breast cancer, like I said, it's been around for like 40 years, 30 to 40 years. Tamoxifen has been around for 40 years, which is amazing. It is still a very good drug. We haven't found, for its class of drugs, we haven't found anything better than tamoxifen for young premenopausal women. Now, it's because it's been around for so long. If you Google stuff about tamoxifen, you will see a lot of bad stuff because people tend to, on Google, talk about a lot of the bad stuff. But it's still a very important drug. It still reduces the risk of relapse of breast cancer by about 50%. So, but there are, of course, side effects. And the side effects, as I always tell my patients, are that it's like having menopause early. So now tamoxifen is usually only reserved now for use in younger patients, so patients who are yet to hit menopause. But the side effects you might get will be menopausal type of side effects. So hot flushes, mood changes, cognitive changes, meaning that you might feel that you're not thinking as fast. Some women get weight gain as well. So those are the typical kind of side effects that you will get with menopause. Now, if you don't tolerate it well, there are other options. So sometimes we can switch to other types of treatments, and obviously there are what we call the aromatase inhibitors like Femara and all that. So sometimes your oncologist will talk to you about, if you don't tolerate it well, we'll switch it. And then in terms of duration of treatment, in what I tell all my patients is you just got to be prepared. You generally will need to take it for at least 5 years. Some will need to take for 7 years, and some will need to take for 10 years. So that all comes back down to what your risk of relapse is. So that's where the oncologist will tell you and guide you, but it's 5 to 10 years duration.
Okay, that's great. Now, the other things that a lot of people are very worried about side effects of chemotherapy, and some of them actually worried that chemotherapy kills good cells as well as cancer cells. And also they're worried about this other condition called chemo brain, and also the other risk factors. What do you think of chemotherapy? What's the general things you want to advise on the participant?
Yeah, look, so chemotherapy, right? Like I said, we all know that chemotherapy is not easy. Side effects are, the typical side effects are hair loss, tiredness, nausea, and your immune system drops. So it is not an easy thing, which is why even us as oncologists, we will not recommend chemotherapy unless we feel it's absolutely necessary. So if your risk of relapse is high, our goal as doctors, right, all of us, you know, the surgeons, the medical oncologist, is only advised for those patients who we know are at high risk of relapsing. If we feel you're at high risk, then you have to weigh up the benefits versus the side effects. And so we know that the benefit is there, that if we give you chemotherapy, the risk of you ever getting cancer again will drop. And so we'll walk you through, we'll hold your hand and help you through that difficult period. But there will be a difficult period where you have to go through all the side effects. Having said that, nowadays, the side effects are much better to tolerate because the drugs are better. And obviously, the supportive medicines are better, meaning that the nausea medications are better. You know, and for women who are afraid of hair loss, we have things like called the co-cap to prevent the hair from dropping. So there's things like the supportive side of things have also improved. So chemotherapy has become a little bit easier to tolerate, I must say.
Okay, that's good. Thank you very much. Actually, there's another question. This is a more specialist question. How about zoometer? Or what is the role of zoometer in
Zoometer has a very specific role for only postmenopausal women. So if you already hit menopause, some doctors will recommend giving zoometer. Number one, to strengthen your bones, and it has been shown that when you strengthen the bones, perhaps the risk of the cancer spreading to the bones will be less. And also, there is a slight benefit in a slight anti-cancer effect as well for zoometer. Now, it is definitely a treatment option that needs to be discussed with your doctor. Not every patient will need, I have to say, will recommend it as well. The benefit is not huge, but if once again your doctor feels that you have a fairly high risk of getting the cancer again, you should do whatever you can to reduce that risk, then they might recommend zoometer.
Okay, so last questions I just want to ask, what do you think of the role of, some patient want to try on high antioxidants and multivitamins and role of alternative medicine in breast cancer? So what do you think of that?
Okay, look, I think with all these vitamins and alternative treatment, we will all honestly tell you, and we've all, all of us here in this webinar have looked at this, well, easily. And if you combine our experience, we look at thousands of breast cancer patients. And most of us, I think all of us will tell you that these things, if you give it to a cancer patient just as treatment alone, it doesn't work. It just, there's no benefit of all these things in treating the cancer. Now, if you want to take it for other reasons, not to treat the cancer, but some people take Chinese medicine to say they believe it makes them feel stronger and all that. Our reservation would generally be, we just don't want the alternative medicine to interfere with what is known to work, which is the treatments that we are offering. So we know that, for example, some chemotherapy will interact with certain Chinese medicines and can give liver failure. So we are very careful about the combination of doing it together. Now, when you finish all your treatment and you want to do all of that, the vitamins and all that, we are all quite I think most doctors are very comfortable. We just don't want you to deny yourself the best chance of beating the cancer by doing something in combination that reduces the effectiveness of your treatment. So generally, we can't say any of us we can't recommend it. We're comfortable with you doing it if it doesn't interfere with your treatment. But none of it has ever been shown to actually cure or get rid of cancer.
Okay, thank you very much. Now, Jen, can you just answer the questions that some are still posted online and maybe personally answer to the chat function, the Q&A, okay, while I give the last talk of the day. And so my name is Dr. Choo Bok Ai. I'm a radiation oncologist, and that means I use radiotherapy to treat cancer. So I work in this field for 18 years already, and my expertise includes using advanced radiotherapy technology in treating breast, gynae, head and neck, skin, and sarcoma cancers. So in 2010, I actually set up a cancer support group, which is a nose cancer support group, and started a befrienders program, which is a peer-to-peer supportive service, because I think that it's very difficult to walk the cancer journey alone. So if there's somebody who actually have gone through the process itself and able to help you go through it, it'd be much more better, because I don't have cancer. and I don't know how difficult it is to go through it. So I think if you have other people who go through the journey, it would be better. So that group has actually been quite successful. So in 2016, I founded another group, which is the Singapore Sarcoma Support Group as well. In 2017, I founded the Dream Maker, which is actually an initiative to grant wishes to patients who's terminally ill. I'll share about that later in my talk. And I'm currently the chapter chairman of the Radiation Oncology in the Academy of Medicine of Singapore. So actually that brings me to my talk, and I just want to tell you that the talk itself, some of you may not need to know as much as the radiotherapy as per se, but I'm just going to go through you some of the things I think is important to know. And hopefully you won't be too scared of radiation after I finish my talk. So we know that breast cancer is the #1 cancer in Singapore and actually around the region as well. So 29% of all female cancer in Singapore are breast cancers. And this is actually double the number of colon cancer, which is the second most common. Now, what happens in the last 30 years that the breast cancer is actually increasing in incidence. So you can see in these slides, right, that the purple line, is breast cancer in here. And you can see that the breast cancer risks have actually gone up 3 times. Yeah. Now, but the good thing is that the cancer survival has actually increased because there's more treatment, from better surgery, from better radiation, and from better, just the chemotherapy and the targeted agents is so much better that the survival has gone up in 1973, and that's the year when I was born, from 25% to 30% only in 1973, and 40 over years later, it has gone up to almost 60%. So there is a 3 times increase in the survival rate because of better technology and treatment. Now, the brief history of radiation actually is gone down to more than 100 years when radioactivity was first detected by Marie Curie, and she got a Nobel Prize because of that. So this is how the radiation machine looks like. It's a linear accelerator. It comes from the head of a machine, and this delivers ionizing radiation, giving to kill cancer cells. And you can see in this patient, the left breast is exposed and we're giving radiotherapy to the left side of the breast. Now, this radiation caused the cancer cell to die, but also the normal cells within the surrounding area as well. But the normal cells, there are plenty, and they usually regenerate and they go back to normal as they can repair themselves. Now, for the radiation, it eliminates cancer cells that may be residual in breast after surgery. So when Dr. Tan talked about breast conservation, that means that the cancer is removed as a lump. So only the lump has been removed, but we do know that if the cancer can develop either in the same area or in other parts of the breast in time to come, a few years later. So by giving radiation, it actually allows the patients to only have a lumpectomy and also reduces the cancer recurrence similar to a mastectomy. So a woman now do not need to undergo complete removal of the breast and can save the breast. And with lumpectomy and radiotherapy, the outcome is the same as a mastectomy. That is for early breast cancer. And we also know that the local recurrence actually drops from 26 to 7% because of that. Now, after mastectomy, people will ask, do I need to undergo radiotherapy as well? The answer is sometimes for large tumor, more than 5 centimeters, that's considered stage 3. And for patients who have positive lymph nodes, axillary lymph nodes, because the lymph nodes has actually been involved, so radiation actually reduces the risk of it spreading further. And again, it reduces local recurrence from 30% to under 10%. So in these 2 indications, radiotherapy is most commonly used. Now, if you look at the clinical data over the last 1991 until 2004, and the reason why I choose such old studies is because these are long-term survival patients, which is actually 15 to 20 years follow-up. And the data have suggested that whatever the baseline risk of cancer relapse, radiotherapy reduces it by half in the breast and wherever the radiotherapy has been targeted. So multiple clinical trials have shown that there is local failure rates has improved with radiation. You can see that in this local failure rate has actually all improved. Now that transpired to actually a survival benefit of here, you can see that 5% and actually increases more benefit if there's a lymph node involvement as well. And that actually goes up to about 7%. Yeah. Now, how do we do radiotherapy is that we need to use a small permanent tattoo on the chest wall because radiotherapy is actually accurate. The accuracy is less than 5 millimeters. So every time when the patient had radiotherapy, we must make sure that wherever we aim is accurate and targeted. And the CT simulation is done just about 1 to 2 weeks before the start of radiation. And this is what we will get. And we can see that the lung areas and the heart area and also the bilateral breast in this CT simulation scan. And with that, we'll draw where we want to aim the radiotherapy. And you can see that this is the left breast that's been drawn on the red color and yellow color. And this is where we want to aim. The pink color area is where the lumpectomy scar was and where the previous cancer was. So this is the area we want to aim, is to treat the whole breast and with a higher dose at the lumpectomy area. And sometimes when there's a spread to the axillary lymph nodes in the armpit, we also give radiotherapy to the level 1. You can see L1, L2, L3, L4. This is the regional lymph nodes that is involved in the radiation for breast cancer, because there is a risk that the cancer can spread to this area. And sometimes they already has spread to the axillary lymph node. So we need to cover it, and we can actually still cure patients and reduce the risk of relapse. Now, how often do you need to do radiotherapy? After breast conservation, which means that usually it's about 3 to 4 weeks, and each time you come is about 10 minutes. It's a consecutive 5 days a week. And the reason why we do it over 3 to 4 weeks, because every day we have to give the radiotherapy slowly. If you give radiotherapy too fast, the skin reaction is going to be quite bad. So we need to stop treatment on Saturday and Sunday to let the cells recover. So this 3 to 4 weeks is standard worldwide wherever you go. And radiotherapy is given through a radiotherapy machine. And when you actually come out from the radiation, you are not radioactive. So you can continue to work and actually drive while on treatment. I can say that can work. And the reason is that radiotherapy is only targeted to the breast area. So you will feel well enough actually to go back to the office work, and you do not have to worry about infection risk. You don't have any hair loss, no nausea and vomiting, unlike some of the systemic effect of chemotherapy. So patients do feel quite well while on treatment, and you will not be radioactive and interact with children if you have young children at home, interact with pregnant ladies, and there's no restriction on food and drinks. Now, the common side effects is that the skin is the most commonly affected. It's because it's like radiotherapy to the breast itself will hit the skin first before it goes deeper into the breast. So the skin will become red after 4 to 5 weeks. And sometimes the skin will peel off, but just like sunburn, it will actually get better after a few more weeks. And usually the breast go back to normal after 3 to 4 months completely. Just there's a bit of mild breast swelling, which is actually temporary, and a bit of dry cough. Now, the permanent and uncommon side effect is that the skin gets a bit more dry later on, and you need to use moisturizer on a longer period of time. The lung gets a bit of scarring, and the small risk of rib fracture, less than 1%, and small risk of secondary cancer, which is again about 1%. And if there is a heart inside the radiotherapy field in the left side of the breast, and sometimes the heart get a bit of increased coronary events, which means the heart get radiotherapy, and 1 to 3% risk of actually have heart problems later in life. Now, these heart problems is actually what reduces the survival of patients. And for me, I am actually reducing the radiotherapy to the heart. In this patient, you can see that the heart, which is actually the bigger heart here, this area. So the heart is inside the radiation field in the complete redness, So a lot of heart is inside this patient. So in this patient, although the patient can be cured of breast cancer, but 10 to 15 years later, and the heart, will have some toxicity from the radiotherapy, and the patient have higher risk of getting heart attacks and heart failure. Now, to do this, the technology that we use an active breath hold technique. What it means that a patient has asked to take a deep breath in for about 38 seconds. And while they're holding the breath in, the radiotherapy is given. Because when you take a deep breath in, you move the breast and the chest wall away from the heart. And that is the thing that we see here in this slide. You can see that there's a free breathing and a deep inspiration breath hold, that the heart, which is actually in this lump here, is no longer inside the radiation field as we breathe in and hold the breath while radiotherapy is being given. So this is called active breath hold technique. Now you can see that in this an X-ray that we do, that the darker area is actually the heart, and we're radiating the left breast. But we take a deep breath in, and the heart volume actually get less irradiated, and just a little bit of heart volume left. We actually can shield it on the radiation machine, and we can actually totally shield the heart commonly now in all my patients that I treat now. device to use this active breath hold. That means that you use a computer software planning to actually do that, as we can mirror and image the chest wall rising up and down. Now, when a patient has bilateral breast, and sometimes it does happen, about 7 to 8% of patients do have bilateral breast cancer, and we actually can treat both breasts at the same time if the breast cancer is detected at the same time. And you can see here in this patient, we're treating the left and right side together. And in this picture as well. So the radiotherapy technique now, we can actually treat quite a lot of areas at the same time, and actually improve the outcome faster because no longer you have to do 3 plus 4 weeks, and then after that another 3, 4 plus weeks. So you actually can minimize the time of treatment by doing it concurrently. And we also have a very high-end robotic couch now, which means the machine can actually position itself and in a few dimension degree of freedom, so that whatever there's rotation and up and down, we can actually correct this while the patient is on treatment. I won't touch on this treatment for this because we're only talking about early breast cancer. I'll talk next time, if there's opportunity, we talk about advanced breast cancer. When the breast cancer already spread for stage 4, let's say in going to the lung, go to the brain and the liver, and how we use this technology actually to target this area when they are spread somewhere else. Now, that is the talk on my breast cancer. I'm just going to talk about a bit of survivorship, because early breast cancer have a high chance of being cured. And because of that, a lot of people will beat this cancer. So this is my nose cancer support group. And this is when in 2018, we sang for the president during the Healthcare Humanity Awards. And, and sometimes we get newspaper cutting and all that presentation, because I just talked about, 过来人. 过来人 is those who survive their cancer, are the best one who actually will come back to help each other survive the cancer. The newly diagnosed patients survive the cancer. And we go on radio, in Malay, in Chinese, and quite a lot of people are now more aware of breast cancer. So October is a breast cancer awareness month. So sometimes we have the opportunity to go on radio and TV to talk about these things. And actually we make a lot of friends and make a lot of, these are all cancer survivors, by the way, beside the DJ, Anna here. The others are actually, both of them are stage 4A nose cancer, and they're alive and well. And actually they become my friends. We used to sing karaoke together. And sometimes we actually go for cooking shows as well to talk about life after cancer. And then there's talk about fulfilling a dying wish of a terminally ill patient. Sometimes when cancer cannot be cured, we also need to make sure that, life goes on, and we continue to actually appreciate life, and we still able to enjoy life. So don't be so, depressed, be a bit more positive, because whatever it is, listen to your doctors and your other people who support you, your family members and other cancer survivors and patients who actually can walk the same journey with you. And this is what happens, that when I took the patient to Japan and Hokkaido, that's what we did, because he wanted to go for white water rafting. He's only 27 years old and he got stage 4 brain tumor. So we went and did something that none of us had done before. And this is really awesome. If you type awesome in the chat group, awesome, because sometimes when you realize that you have cancer, or you saw your family or your friends have cancer, then you always think to myself, do I really need to work so hard? Do I really need to, do a lot of things that I wanted to do, but put it up until the end, So actually in this area, you just have to think about yourself. Whatever you have pleasure, whatever you like to do, whatever you can spend time with your family, create memories that will last for a lifetime. Because I still remember this journey with my patients when we went to Hokkaido, because we add a lot of things, Wagyu beef, we do a lot of things that I've never done before, and this is with my patients, so it's really quite meaningful. So there is two things that I working on the project. Is not available yet, but sometimes sometimes the books actually can help doing that. Have a guide in cancer, and this is my my email. If you want to think about a cancer bootcamp and books later, and when it's available, you do drop me a line at the Bok Ai Choo at icon.team. I'll take some questions later, but you should type bootcamp, just know that you're interested, and you say that you will want to know more. I say, just type in, I want to know more. And then we can actually contact you if there are any other further seminar available. So thank you for that thing. Now I just have to cue myself, because now I have to answer some of the questions if that's available. Some of the questions are mainly, still directed to Dr. Yip and Dr. Tan. Just some of the, I'll just look specifically at the radiotherapy question now. Why does radiotherapy cause fatigue and tiredness? And the answer is that when radiotherapy is aimed at one particular area, let's say the breast. Now, when there's dead tissues caused by the dead cancer cells, and also some of the normal cells actually do die. So what happens is that the body tries to get rid of some dead cells, and because of that, it went into a higher metabolic drive, and that's why the patients get tired. So even when you're sleeping, the body is trying to work to try to address that the getting rid of dead tissues, and that's why you get a bit of tiredness because of that. Now, there's another question that function, will I be able to function normally as someone go to work? The answer is yes, you can go to work during the radiotherapy session. There's no problem at all. Yeah. Now, so some of the questions, they may not available yet. I'm just going to answer. After that, I'm going to open to the whole panel to answer. So this is a question on diet restriction of food to avoid for breast cancer. So I answered that for radiotherapy, there's really none. For diet restriction, sometimes some of the chemotherapy, some of the fruit like grapefruits can affect the metabolism of breast cancer. So I just asking the panels now to turn their mic on, and I will probably answer some of the questions together as a panelist together. Okay, Shang, are you on? Do you want to answer any diet restriction to avoid during chemotherapy for breast cancer?
Wow. Okay. 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 During chemotherapy, actually, amazingly, there's only really one particular thing that we definitely tell all patients you definitely cannot have, and most Singaporeans don't have it, and that's this particular fruit called grapefruit. Grapefruit, it specifically interacts with a lot of chemotherapy drugs, and so you can't have it during chemotherapy. Thankfully, very few Singaporeans eat grapefruit, and also the whole class of fruits, all the other fruits that look like grapefruits but it's not grapefruit, you can have it. So like, you know, grapes, pomelo, oranges are fine, but grapefruit in particular, we tell them not to have it. So that's number one. Number two, we try to advise most patients also to eat cooked food. So try to avoid raw food during chemotherapy. So no sashimi during your chemotherapy, and try to make sure everything is well cooked. We just want to lower the risk of patients getting infections or food poisoning when their immune system is already low. And then other things are not so important, but little guides, you know. But we usually advise a higher protein diet because that seems to help with their recovery during chemotherapy. And we say, you know, the usual normal healthy diet that we would normally advise for everybody: lots of fruits, lots of vegetables, you know, less fatty, less sugar, less oil. These are all basic principles that you can do during chemotherapy and after chemotherapy.
Okay. How about Dr. Tan? Any food that about surgery? What do you advise of those who had surgery before? What is the food that will improve their recovery, if there's any?
Yeah, I think in our Asian culture, a lot of patients be worried about the scarring. So all the old wives tell about don't eat dark soya sauce and all that. I want to state here as a fact that there's no proof of that. Okay. Food restriction. I think again, our culture, a lot of us may take supplements, traditional herbal supplements and stuff. For things that are ginseng, ginkgo based for memory and all that, it's good to stop all that for at least 1 week before surgery. The reason is some of these medicines may interact with the medications for anesthetic or for antibiotics, and that can, or they can cause increased bleeding. So that actually complicates the surgery. Otherwise, for the surgery itself, no real food restrictions.
Okay, thank you. So some people were asking still of why cancer relapse. So there's a question, yeah, there's a patient who is the stage 2 cancer on one side, which is HER2 positive. Then 2 years later, it came back again. So why do cancer relapse? We ask Shank.
Okay. Yeah, it's a difficult question to have to answer. Not because we don't know the answer, but I guess if it's a personal question, I'm sorry that happened. The why do some cancers relapse is that we know that most cancers are curable, but obviously that means there is still a small group of patients that will still relapse despite having all the best treatments. So your doctor may have recommended all the correct treatments, and there will still be some cancers that don't behave the way that we expect them to behave. And that's just how cancer is. There are certain mutations that we probably don't know about. There are certain cancers that look as if like they should be behaving a certain way, and they don't. And that's just how complicated cancer is. So despite our big advancements in how we treat, there will still be a proportion of cancers that will still relapse despite having had the best treatments and the patients having behaved themselves, done all the best things. There will always be a small group of patients like that. Now that number is getting less and less for early stage breast cancer, but it's still there so that we will only get to zero relapse when we are able to actually find an amazing way of curing all cancers one day, and hopefully we're taking baby steps towards that.
How about Yason? What do you think of lumpectomy and mastectomy? Some people worry that if I don't remove the whole breast with lumpectomy and radiotherapy, there's a risk. Have you seen many relapses after normal lumpectomy? And will a patient relapse after mastectomy? The breast is no longer there. Why do they relapse then? Have you seen it?
So I think this question came up in the Q&A once or twice. To help the audience also understand, when cancer comes back, I think of it as there are two ways it comes back in. One is within the breast, or rather, one is within the breast, one is a new cancer in the opposite breast, and one is the original cancer coming back to other parts of the body. So when in terms of choosing the surgery, that will affect whether or not the cancer comes back to the same breast. So between a mastectomy and the white excision with radiation, in the long term, the risk of cancer coming back to anywhere in the body is about the same, right? Correct me if I'm wrong, right, Dr. Choo? But for local recurrence, that means whether the scar area has cancer coming back, the white excision radiotherapy has a slightly increased risk compared to mastectomy. This is a very simple logical reason. When we do a mastectomy, the technical step is such that we leave it as pi-pao. So only the skin and a bit of fat covering your bone. There's hardly any visible breast tissue left. With that kind of a removal, almost no breast cells is left, or a chance for cancer to grow back. So over a period of 5 years or 10 years, only a handful of patients will have cancer coming back within that flat skin. Compared to the white excision with radiation therapy, despite the best surgery technique, despite the best radiation therapy, perhaps about 5% of patients may have a small cancer coming back around the scar area over 5 years. So in that situation, if we do diagnose a cancer recurrence to the breast, what I do is to do a whole body scan to confirm there's no spread elsewhere. Then in a way, it's just a matter of removing the cancer now and converting the lumpectomy to a mastectomy, and the patient still gets to have a cancer-free survival in the following years.
Okay, that's good. Thank you. Now, Shane, I want to direct your questions. Sometimes people are still asking, when do you really need to decide how you decide to give patient chemotherapy or not? Let's say for stage 1, you talk about Oncotype. How about stage 2 and 3?
Yep. So the general principle is we look at how aggressive the cancer is and what's the risk of it relapsing. So how do we decide how aggressive a cancer is? So we look at two things in general. One is obviously the stage. So if you have a more advanced stage cancer, even as early stage, like if you have a stage 3 breast cancer, almost all stage 3 breast cancers will need chemotherapy because they are more aggressive and a higher risk of the cancer relapsing. Stage 2, a lot of stage 2 breast cancer patients will also need chemotherapy, but some can get by without it. And then for stage 1, most stage 1 breast cancers will not need chemotherapy, but some will still need it. Now, so besides stage being the one quite important, the second thing is then is to look at the type of breast cancer. As you know that there are different types of breast cancer. We can mention a few briefly. I mentioned a few briefly earlier. There is the hormone-sensitive type of breast cancer. There's the HER2-positive breast cancer and the triple-negative breast cancers. The more aggressive types of breast cancers are cancers like your HER2-positive breast cancers and your triple-negative breast cancers. Usually for HER2-positive breast cancers and triple-negative breast cancers, even if you catch it early, like stage 1, you will still need chemotherapy. So usually there will always be a team, the surgeon, the radiation oncologist, medical oncologist, we come together to decide exactly who are the patients who need extra treatment. So same as just as how I would decide who needs more chemotherapy. Some likewise, Dr. Choo will see a patient to decide and look at the similar kind of things to decide who needs more radiation treatment. So we look at these two main things: the type of cancer it is, the type of breast cancer it is, and the stage of the breast cancer.
Coming to the stage, maybe I'll just ask Yaswan, just how do you stage breast cancer? Because some people are asking, is PET scan necessary to stage patient?
Yeah, so I think it just happened that, as a surgeon, most of the patients start with me, right? And my practice is to warn cancer patients that among the specialists, we have a very defined way of defining stages. So that I actually share with them the medical knowledge of something called the T, N, and M status. So T refers to the tumor size, N refers to lymph node, and M is metastasis, spread to anywhere. So spread is either yes or no, okay? So N is complicated. There's 0, 1, 2, and 3, depending on number of lymph nodes. And T is the size of the tumor, again, depending on centimeter. And the challenge here is when I see a patient with a certain size tumor on the ultrasound, I do warn them that the final surgery specimen, the tumor might be just slightly larger or just slightly smaller than the ultrasound size. So most times it'll be the surgery to conclude the T and the N staging. The M staging, I will define through a PET scan or CT scan with bone scan before I hand them on to my two colleagues here to specify the subsequent treatment. So for the patients for the viewers who actually ask about staging scans, I did answer and ask them to clarify with their doctors. Are their cancers in fact invasive cancer, or could they be having DCIS? Because DCIS cancer is very early stage cancer, and the theory of it is that it does not spread at all. So that could be one very logical reason why your doctor did not send you for a PET scan or any kind of scan. Another answer I reply is that depending on the doctor's training and experience, some doctors may choose to recommend other types of scans to check for spread elsewhere. So do clarify with your doctors, not that they did anything wrong or that there's only PET scan available. Yeah.
Okay, thank you. Sheng, there's a question about cold cap. Where is it available, and is it widely available? And any risk of getting using cold cap?
Okay, it's available. I would think most private settings, certainly in Icon, all our clinics have cold caps. In the restructured, it's not available in Dundalk saying. I'm not sure whether it's available in SGH or NUH. It is a supportive thing, so I don't know whether restructured hospitals will offer it, but you certainly in the private setting, I think most private oncologists will have the cold caps available.
Okay, thank you. There's another question, Sheng, about numbness on the fingertips. So the chemotherapy actually can cause numbness of the fingertips. And how long does it last, and will it get better, and what do you do about it?
Yeah, that was my next question. Okay, I'll answer it live then. As an oncologist, I hate the numbness from chemotherapy. We've taken such good care of and helped to reduce the side effects of chemotherapy for so many types of side effects, but we haven't really we haven't made much improvement in looking after the numbness from chemotherapy. So the numbness comes from a particular chemotherapy drug that we use for a lot of breast cancer patients called Taxol or Abraxane. Up to almost 70% of patients will get numbness if they need this drug. And it's still a very important drug. So most patients, we won't simply recommend it unless you really need it. But if you get it, there's a high chance that you will get a numbness. At this moment in time, there isn't really a great way to prevent the numbness except to pray and hope for the best. We've tried many different medications over the years and nothing seems to work. The only thing that may work a little bit in preventing it is what we put, making the fingers or the feet really cold during the treatment. So some clinics, like my clinic, we offer like cold gloves. They put patients in cold gloves during chemotherapy for the Taxol, and that seems to reduce the numbness. However, a lot of patients still get the numbness even despite all the cold gloves. And once you get it, it's very different for every single patient. Some patients may get it for a few months and then it goes away. Some people will get it for 1 year. Some can get it for 2 years. Some people can get it forever. in general, if you get it, it will get better for most patients, but it can last for a long time. We try many things like vitamin B to try to reduce it, and some people may need to reduce the numbness, and also things like some specific numbness tablets like Lyrica. And but we have to be honest and say there isn't a fantastic way of treating the numbness at this moment. Now, there is something on the horizon. There are some new trials of some new drug that's probably going to come out in the next few years, and it looks promising. And so hopefully in a few years' time, this will not be a problem. But right now, still a problem.
Okay, thank you. Now I'm going to answer a few questions about radiation. Some people are asking whether the skin will chow da or not on the chest or the breast area after radiation. The answer depends what you mean by chow da. It won't chow da, it will be suntan. So it'll be a bit chocolate because of the radiation effect. What happens is that I recommend regular, like something like aloe vera or moisturizer. You can use QV cream, aqueous cream, which is Cetaphil, Physiogel. And there's a new medication called Strata XRT, which is specifically licensed, specific indication used for this. So you can ask your oncologist, radiation oncologist about this specific cream. But most of the time, the radiotherapy dose is actually not too high to cause irreversible skin changes. It doesn't. So actually, you all get better, and just take it as like a suntan. You actually improve with time. But sometimes, if the chest wall is actually quite thin, there are more people also susceptible to radiotherapy. So different people have different skin setting in the sense that their sensitivity is different. So majority, I would say that all my patients do recover from this skin reaction. So don't worry about it. You will get a bit uncomfortable, but you will get better. Now, the other thing that I can answer is that, do you take soya products and dairy products and antioxidants? So these are very common questions in that. Probably I'll ask the panelists as well, but I'll answer it first. For me,
it's just about
everything must be in moderation. There is actually no proof at all that if you take a very, very high amount of soya or dairy products, you will get it. The reason is because why that actually comes on is because sometimes, there is a bit of estrogen, which is called phytoestrogen in some of the soya products, and produces a mild estrogenic effect. But the estrogenic effect on it is actually very, very mild. Unless you consume a huge amount every day, it shouldn't cause a problem. Now, if you have an ER positive tumor, actually you are using tamoxifen or Femara to block it anyway. So actually, I say that, don't worry too much about it, a little bit. And the same thing that is now durian season. I just add durian, by the way. So anyone, you like durian? I'll ask you to type durian inside. But actually, sugar, does it fit cancer? The sugar actually itself, now, and you take in sugar, the body regulates it and reduces the amount by producing insulin. Now, we do know that for patients with diabetes, there's a 2 to 3 times higher risk of getting cancer. It's because there's dysregulation of this sugar control. But if you're a normal person, you don't have diabetes, and you take sugar, a little bit of sugar, and the body will actually reduce the sugar quickly in the body by producing insulin. So actually, for myself, I've stopped taking any processed sugar for a long time. I don't take any sugar in my milk, in my tea and coffee at all. So that is my personal preference, because sugar is not good, especially processed sugar. But sweet things, sometimes, take in moderation, but don't take too much. But don't worry too much that you say that from now on, I'm not taking anything sweet. That is actually significant reduction of your quality of life. Now, how about your panelists? Yiswan and Shang, you all can answer. What do you think about sugar? I know Yiswan likes to take ice cream, correct? I like ice cream.
How should I put it? I think I am fortunate in that, of course, I myself, I don't have cancer yet, touch wood, but I am also quite realistic. I think in our modern life, the kind of processed food we eat, even radiation from computers, radiation from the sun, I believe I will get cancer at some point in my life. All right. This is not being pessimistic, it's just being realistic. So in balancing a treatment for cancers, the other thing is to learn how to enjoy life and appreciate life. So yes, everything in moderation. I'm plump but not fat. I don't think I'll ever be so stringent to control my diet 100%, but I will try my best not to take extra things that will do harm. So in relation to soybean, I've always jokingly tell patients how much tau pok, tau hua, tau hui can you eat for it to trigger cancer, right? If you're taking Mr. Bean once a month, once a week, that amount of soy should not cause any harm. But for the Chinese vegetarians, if their only source of protein is from soy, I do caution them to perhaps substitute some other kind of protein inside, such as lentils, chickpeas, yeah, just to reduce the soy content. No true evidence base, but just to spread out the exposure.
Okay. Shane, what do you think? Do you take any sugar?
Yeah, look, I don't take much sugar, like you, Bob, and but I don't do sugar not because I don't really believe that the sugar, if you, so what I'm saying is if you avoid sugar completely, you may still get cancer. So I don't reduce sugar just because trying to avoid cancer. I think I reduce sugar because I'm vain. No, I reduce sugar. And and I don't want my kids to keep, when I do get fat sometimes, like during the circuit breaker, my kids are very, very quick to point out how I'm getting fatter. So I think there are other reasons why I don't take too much sugar. And like same with like fatty and unhealthy food, and obviously health, but I do think about as a holistic thing. If you reduce your sugar, your fatty, and you eat well, obviously there are heart problems that you will help to reduce, diabetes, and I think about all those sort of things. I have to say I do it more for those things rather than the anti-cancer benefit.
Okay, thank you. I think I've got a cue from the host that we only have a few minutes left. So some of the questions we cannot answer everything. That's why I thought that maybe next time we have opportunity, we can talk about some of these issues. That's not really directly talking about early management of treatment, but actually a lot of these questions are actually quite important because we got asked a lot of times by our patients about diet, about exercises. And that's why I thought a cancer boot camp will be a real time, we can spend a few hours talking on real issues of things that concern to you. Now, if you wish to contact Dr. Tan, Dr. Yip, and myself for discussion, you can refer to our contact details or drop us an email. If you like, well, I would like to ask you a simple poll actually to gather your feedback about today's program. So if you can answer, if you can just kindly, just take you like few 10, 20 seconds to fill it out, quite easy, yes and no. Maybe it will help us to how to conduct the program again, in a similar platform, or we can actually take it offline and go to a more detailed platform for that purpose. So our next webinar, we're thinking of doing it on the management of advanced breast cancer, no longer on early, because advanced breast cancer, let's say for surgery, may involve some plastic surgery as well. And then advanced breast cancer also means that we have to treat liver cancer, spread to the liver, the bone, and all that, and radiotherapy, what it can be done to that. So there's another talk altogether. So if you're interested in subsequent sessions, and do indicate in the poll that you actually see on your screen now, I'd just like you to fill it up. I hope that you find the session actually quite enjoyable. I've learned quite a lot because sometimes when we have to ask questions before we know the answers, and sometimes I learn from my colleagues as well because I don't know everything. But with the shared experience, we hope we can learn from each other. I also continuously learn from my cancer survivors and my patients, how they actually look after themselves during that. They actually share with me a lot of recipes, You want to know what food to eat during cancer, you join my cancer bootcamp, I share some of the recipes with you. And with that, with the poll, just continue to fill it up. I'd like to thank the management of Thompson Breast Center and Icon Cancer Center, who also was our event partner, which is Roche, and that they help us do a lot of things at the back end to make this possible. I'd like to thank two of my colleagues. Actually, we worked together as a team many years ago in Tan Tock Seng, and we're still working together now. We hope that you will have enjoyed this talk and learned something. Do drop us some email if you want to know more. But we have tried to answer as many questions as possible. But sometimes the question will not everything be answered. There are many webinars available. So hope that you can actually join other webinars as well if necessary to learn more. But we are all friendly and available. So I want to wish everyone a good health and a great week ahead, and hope that all of you have enjoyed today. So we're on time, 3:30. That's the end of our webinar. Thank you very much for attending. See you.
Thank you.
Okay. All right. Have a good day, everyone. Bye-bye.
Enjoy your phase 2.
Yes. Go shopping.